My stethoscope is a crutch. My CT scanner is a crutch. My job is not to keep my life as intellectually interesting as possible. My job is to take care of patients and make them better and try to do it at the lowest possible cost and friction. Ask the big fundamental questions. How does this influence the payment system? Will there be doctors in the future? Who's going to win, startups or Epic or Google? If doctors saw their jobs as being at risk, we would push back on this really hard and we wouldn't welcome it into our world. And that would kibosh AI in healthcare. And we wouldn't say, we don't want it because my job's at risk. We would say, we don't want it because it will kill you. And most people will believe us.
Hi, everybody. Welcome back to Lifers. We've got an incredible episode for you today with actually, I would say, a friend and longtime mentor of mine, Dr. Bob Wachter. You may know him from his seminal book, The Digital Doctor, which really covered a lot of the technology trends, including AI, so many years before they became the hot topic. And now he's out with a new book called A Giant Leap: How AI is Transforming Healthcare and What That Means for Our Future. So I'm really excited to have him join us, talk to us about his previous book, current book, everything that he's seen in his life as a physician, executive. He's also at UC San Francisco, has seen so many waves of technology move into healthcare through his career. Bob, I'm going to ask you a question right off the bat, now that you've written this new book, which is AI any different?
Totally. I think the technology is remarkably impressive, but I think in some ways more impressive is how desperately the healthcare system needs it. You know, on November 29th, 2022, the day before GPT came out, I wasn't sitting there saying, I need something better than Google. I couldn't even imagine what better than Google would look like. And yet in healthcare, I can't find anybody who thinks the system's perfect and we don't need to improve. So it really is a combination. What makes me actually pretty psyched about this, it's a combination, Chrissy, of the technology is different and very cool and does some things that healthcare really needs. And healthcare is desperately in need of digital transformation. And I think the combination is what's remarkable at this moment.
Yeah, so I was recently at a panel in healthcare, and it was a group of physicians talking about AI. And one of them made the point that there is still a perception in the medical field that using AI is a bit lazy. It's a bit of a crutch. And then somebody else shot back and said, no, I actually think there is something very wrong with a physician who does not use AI in their practice today, just given that you have at your fingertips within seconds this corpus of medical knowledge that no human being could possibly have in their brain at any given moment.
Yeah.
And this debate just ensued amongst the panelists. Where do you fall on the continuum?
I think the former point is ridiculous. I mean, my stethoscope is a crutch. My CT scanner is a crutch. My job is not to keep my life as intellectually interesting as possible. My job is to take care of patients and make them better and try to do it at the lowest possible cost and friction. And so any tool we can use to do that is positive. In some ways, I don't understand the argument, although I completely do, because the crutch part is, are we going to de-skill? Are we going to become stupid? And is that problematic? Before just sort of saying de-skilling is bad, you know, I have de-skilled on reading a map. I don't know how to do that anymore, and it doesn't make any difference in my life. I rely on my phone for my memory in many cases. I don't remember my wife's phone number, and but that's okay because I have my phone. So in any case, the argument about de-skilling is quite important for those of us in the medical education business, which I am in, because if people use AI as a crutch and don't learn clinical medicine or diagnostic reasoning, and we still count on them to oversee the results of imperfect AI, which it is imperfect right now, then we have a big problem. So I think during this period where the AI is good enough to be useful, but not perfect, the idea of de-skilling is really quite problematic and probably no different than as I think about my life as a writer. If I depend too much on going on to Claude and having it edit my documents, am I becoming a worse writer? Probably. So we've got to be careful about it. But we really have to keep our eye on the ball. And the ball is, what are the tools that we can use to make care better, safer, and less expensive?
So, Bob, one of the things that I loved about the previous book that you wrote, which I mentioned, that The Digital Doctor, you had a second kind of sub-line of your headline of this book, which is hope, hype, and harm. And this book I thought was really good at providing a balanced assessment at what really was the first generation of a lot of these health technology tools, whether they be the EHRs, the early wearables, some of these digital health companies. And then your new book, you talk about the giant leap. So you've gone from, quite a balanced assessment and at times leaning quite skeptical about the role of technology in healthcare to now seeing this massive potential. And where I'm absolutely with you is definitely around the potential of the technology. I'm like you, closely following all the studies that show the incredible accuracy gains, just how quickly this is evolving. These AIs now are passing medical licensing exams at incredibly high rates, getting high marks. The potential here is enormous. But where I feel that skepticism myself is really around the payment model and thinking about this fee-for-service world of medicine. And what I worry about is that some of these tools, take the example of, say, an Abridge or an Ambiance or any of these tools that physicians now use for documentation. One of the ways in which the system pays for these tools is to have more billing, more codes. And that is because of the incentive system. It's the world of reimbursement, the fee-for-service world that we live in. So how do we make sense of all these incredible technologies, the efficiency gains, the productivity gains that we could get from them, while also fitting them into a system that was not designed for AI?
Yeah, I say first off, Chrissy, when I wrote The Digital Doctor, it was because I was really pissed. I mean, it was like, why is this technology, which we've been waiting for 30 years, so disappointing? And why is every doctor I know unhappy about it? And so I wrote it really as the main character is the electronic health record and why things had gone so badly. And one of the take-home messages was, unanticipated consequences are to be anticipated. This is harder than it looks. And much of the value we get out of these tools is going to be through implementation and in the context of the policy environments. You're absolutely right to pay a lot of attention to that. When I started writing this book, and I ended up doing about 110 interviews, I was not sure where I was going to land, whether I was going to land in an optimistic place or a neutral place or a pessimistic place. I landed in a very optimistic place, in part because the needs are so great, in part because the tools are so remarkable, and in part because, yeah, it doesn't do anything fundamentally to change the policy environment, but the policy environment is the one we have today. I mean, it's an environment that is in many ways counterproductive, in many ways drives overuse. I can see how these tools will insert themselves and even in that environment make things better. Now, you may argue that in the current policy environment, we won't use these tools because there may be no incentive to use them if what they're going to do is make care less expensive. I think that could go in a lot of different ways. But to me, if we say part of the big challenge in healthcare is the cost of care, $5 trillion a year in the US and 20% of the GDP, which obviously is true, I could see the tools making care less expensive, but it's not a slam dunk. The two ways it could make care less expensive is by lowering administrative costs and leading to far fewer numbers of FTEs in our healthcare delivery environment. I could see that happening, and it's already going to happen. We have 1,000 people in our billing department at UCSF. I don't think we need 1,000 FTEs of people to do billing. The second way it could make care less expensive is through clinical decision support and guiding me as a doctor to deliver the care that actually is the best care at the lowest cost. Will it do that? Healthcare's pretty good at figuring out ways of not cutting our costs and actually raising our profits. We all operate on pretty slim profit margins. So will it guide me to the least expensive care, or will it guide me to the care that delivers the best reimbursement for my system? I think that's a decision policymakers have to make as they're sort of grappling with this technology, but it will give us the capacity to try to influence the care that's delivered, allow patients to do certain things themselves or with lower priced professionals than seeing me. I think in some ways this is all in our hands, and we've got to figure out what is the policy envelope to wrap this in. But it's hard to believe that having these kinds of tools that can allow us to use evidence in a new way, to deliver care in a new way, and to get rid of so much of the bureaucratic silliness and so many of the FTEs that we just hire and hire and hire, and we can't afford and we can't even find them anymore. It's hard for me to believe that's not net good. And that's partly how I landed in a pretty optimistic place.
So Bob, you've been practicing medicine how many decades now?
I'm pretty old. I've been practicing about 40 years. About
Okay,
40
40
years.
years.
Yep.
If you were just starting out now in the field,
Well, I have a daughter and a son-in-law who are young doctors, so I see this up close and personal.
okay, so let's take them as an example. Is any part of you reacting with fear?
Sure.
Look at what these technologies can do. Is the job going to fundamentally change? We don't know how it's going to change. What about replacing certain
Of
medical
course.
specialties? How scared should physicians be, or should they be, instead kind of shouting from the front lines that they want to use as much AI as possible?
I get this question all the time from people, should my kid become a doctor? If doctors are gone, it means that journalists are gone, accountants are gone, lawyers are gone, writers are gone. All those things happen before doctors because the stakes are high, the regulatory environment is such that, and I don't think people really want a bot to tell them that they have cancer anytime soon. So I think we'll probably be the last to go, but I think we are all wrapped up into that big question of job replacement, which I think is one of the fundamental questions that this raises. For the foreseeable future, this is going to be net positive for doctors and nurses. By net positive, I mean making their lives better, making their jobs better, making their jobs more interesting, taking a lot of the bureaucratic hassles off their plate, while leaving for them things that actually they like to do and are trained to do, which is interact with patients, make hard decisions, make judgment calls, coordinate care. Those are things that I think we like to do. We don't like documenting. We don't like trying to remember the right code in order to get the biggest bill. We don't like trying to figure out how to summarize a 600-page chart in the 2 minutes I have before seeing a patient. And I think politically, is there going to be no job replacement in medicine? There's going to be a ton of it, but it's largely going to be in the billing department, the call center, the prior auth writers, all those jobs that were created around the bureaucracy. I think lots of those, I think we can get by with far fewer FTEs. So the reason politically I think this is quite important, beyond the kind of human issue of people, do they have work or not, is if doctors saw their jobs as being at risk, we would push back on this really hard and we wouldn't welcome it into our world. And that would kibosh AI in healthcare. And we wouldn't say, we don't want it because my job's at risk. We would say, we don't want it because it will kill you. And most people will believe us. And so the fact that I think most doctors and nurses will say, my job's impossible without this. And as we brought in scribes or chart summarization or things like that, and people are saying, my God, this makes my job better. That's really important because what you're doing is getting the endorsement of clinicians, bringing it in. Now, will ultimately it take their jobs? Maybe. But as I tell in the book, and I think you know the story, in 2016, Jeff Hinton, the founding father of generative AI, said we should stop training radiologists today. We already have enough, and it's clear that in 5 years, we're not going to need any. So that was in 2016, 10 years ago. For a couple of years, applications to radiology residencies tanked because the students are smart and they read that and they said, I'm not going to have a job as a radiologist. Today in San Francisco, I get in a driverless car once a week. Trust it completely. We can't hire enough radiologists at UCSF. I mean, truly, we're desperate for more. Our radiologists are desperate for help from AI. So job replacement in medicine is harder than it looks. The stakes are high. The regulatory environment is such that I think jobs are safe for the foreseeable future. 30 years from now, I'll be gone. But for the foreseeable future, I think jobs are safe, and I think you're going to see clinicians welcome this into their world.
Hey, everyone. We'll get right back to the conversation after a word from our sponsors. Today's episode is brought to you by Arbiter, the care orchestration platform. In a healthcare system full of silos, Arbiter is a unifying layer. Backed by one of the largest early funding rounds in health tech history, Arbiter brings payers, providers, and patients together on one intelligent platform, routing referrals to the best in-network option, managing authorizations and outreach, and coordinating appointments seamlessly. See how it works at arbiter.ai.
Yeah, it's so funny because I was in San Francisco a few weeks ago and I'm in New York now. We don't have Waymo yet, but I was with a group of physicians, one of them at UCSF, and he was calling a car and there was an option to get a Uber with a human driver in 2 minutes and an option to get a Waymo, which was self-driving in 10. And he picked Waymo.
I always would. Yeah.
And he said, I would just feel safer, which was, I thought, a fascinating
You
commentary.
not only feel safer, but you are safer. And I could sit in the back seat and sing Springsteen at the top of my lungs. It's pretty terrific. And anybody says, well, AI won't have a role in medicine because the stakes are too high. Try making a left turn onto Visadero Street during rush time. I mean, the stakes are pretty damn high, and it's
I
really
still
pretty
have
remarkable.
nightmares from trying to drive in San
Of
Francisco.
course.
So that brings me to a bit of news that came out this week that I'm sure you saw because
I did.
it was big news, and that was about the state of Utah agreeing to work on a pilot program with a company called Doctronic, which is backed by venture capitalists for a very limited scope where the AI would be fully autonomous over time, no human in the loop. And that's a super important distinction because what we are seeing right now, for the most part, is there is a human physician in the loop. Now, Doctronic has said this is not going to be something, day one after making this announcement where the AI is operating without a human physician paying very close attention. But the idea is with this very limited scope around medication renewals for patients with chronic conditions, the AI could be trained over time to really do this on its own. And this, of course, got a ton of attention in the media. The AI doctor is coming. When you read this announcement, what was your first take on it? How did you react?
Terrific and inevitable. Try to find a primary care doctor in San Francisco or probably in New York. Nearly impossible. There was a study a couple of years ago that said if a primary care doctor only did the preventive stuff that they're supposed to do, that would take 27 hours a day. So we have an absolutely overwhelmed health system. And the idea that you have to contact my office and get through to me or send me an email through my chart for me to refill your statin is stupid. And that's just a waste of bandwidth. It's a waste of our physician workforce, and it's incredibly inconvenient for you, and it's probably cost some money for you that you don't need to spend. We have to take a step back and say there are certain tasks that physicians today are doing that really don't take the physician's training, and we can probably find ways of having AI take over those tasks and therefore allow physicians more time to do what they need to do and make things better, more convenient, and less expensive for patients. Refilling a medicine for a chronic disease and a relatively safe medicine strikes me as super low-hanging fruit. Now, of course, the AMA reflexively came out against this because that's what the AMA would do. But it sort of reminds me of the first time that we began hiring nurse practitioners or physician's assistants. It was like, how can these people do this thing? These are doctor tasks. And now in many cases, the doctors welcome it and have collaborators in their offices who are PAs or NPs because they realize that if we can have other people do this thing that will be more convenient and less expensive for patients, that's good. And I still have a job and I still have an income. And I think it's just inevitable that we move this to AI. The study that at least was cited in the application to Utah said that in looking at somewhere between 500 and 1,000 refill prescriptions, the concordance between what the AI said, yes or no, and what the doctor said was 99.2%. That's pretty darn good. The AI it's not like it just reflexively will refill it. It will ask you, are you having side effects? Are you on new medicines? It strikes me as a perfectly reasonable way of getting started with agentic AI. Of course, everybody is worried about the slippery slope. I don't want AI to prescribe your chemotherapy. I would be very careful about having to prescribe a new medicine for you for now. In the future, though, given the primary care crisis, I think this is the way life is going to go. I think for your basic management of hypertension, obesity, lipids, I'm going to be pretty comfortable with having you have an AI doctor, particularly if it's less expensive and more convenient for you, and reserve the bandwidth of physicians to take care of patients who really need the skills and training of a doctor.
So, funnily enough, I'm friendly with Byron Crow, who I think you may know as well. He's the chief medical officer at Doctronic, the company behind this plan in Utah. And I'm very sorry to tell you all that my first text to him after I saw the news was, tell me about your medical malpractice policy.
Oh, of course. And he's got one.
He's got one. And I'm sure it's an extremely expensive medical malpractice policy, but that's where my mind goes at this point. But to that point, there is this question of liability. And I think some of the studies that you just cited, it really gives me confidence that we can do this in a way that's extremely accurate. But the second that this AI does something that is harmful to a patient, it is going to be front page news of the New York
Of course.
Times. The
Of course.
medical malpractice lawyers will see a huge opportunity. And yet, we accept so many errors, mistakes when it comes to human beings. It happens all the time. So, what is your framework for thinking about liability, thinking about risk in the context of flawed human beings that we accept and allow to be flawed and make mistakes within our current system? And then this AI that's coming along that we can do things far more cheaply. We can serve patients at scale for the first time extremely efficiently. Will probably make the mistakes, maybe far fewer mistakes, but those mistakes will mean so much more on a societal level.
Yeah. Well, it's what happens with any new technology that comes in any industry. It gets, in some ways, over-indexed and over-scrutinized, and a single mistake becomes a news story, whereas all the mistakes that happen in our existing medical system are just baked into, okay, that's, the system's imperfect. I quote Biden's favorite quote I have in the book, and it's one of my favorites, which is, "Don't compare me to the almighty, compare me to the alternative." The alternative is a healthcare system that fails to deliver in many cases and makes plenty of mistakes. I'm not so much worried about liability because at the end of the day, systems will make the choice. All right, we could have a human in the loop here, and therefore this is how much it's going to cost to have these doctors, involved in this process, whether it's reading an X-ray or endorsing a refill prescription. First of all, it probably is not going to buy you all that much safety, because if the thing is right 99.8% of the time, the human in the loop is going to be completely pro forma. And at some point, the humans are going to rebel against having to pay malpractice insurance for something that they're really not doing. Malpractice is just sort of math at the end of the day. If it turns out that this thing is safe and much less expensive to run your practice using AI, you're probably going to be willing to pay liability insurance in the same way you used to have to pay it for your doctor. I think the issue is less about the malpractice risk and more about the sort of brand risk and the newspaper and that kind of thing. And of course, as you well know, the example comes from the driverless car, where there used to be two driverless car companies in San Francisco. One of them, Waymo, the second one, Cruise. Cruise ran over a woman, big malpractice suit, lots of articles, and went out of business in a year. So these things, if we're going to do it autonomously, they have to be really, really safe. We have to build up enough reservoir of trust and data, like the kind that this company built up, that says that in general, this thing is safe. At some point, it's going to cause an error, but the error has to be seen in the context of, what are you comparing it against? You're comparing it against a system that is unsafe. And, I refill a lot of medicines. I'm incredibly busy. It may be that I don't know everything I need to know about how the patient is doing, and I'm not sure this thing is going to be less safe than the existing system is. So I think we do have to gear up for it. There always is going to be a risk that a single error is going to be newsworthy, and people who have a vested interest in the status quo will probably be taking advantage of that error as well. In healthcare, the first case we're seeing this is in the mental health chatbots, where a single case of, something egregious and horrible and indefensible, where it did not tell a kid call a suicide hotline, but rather kind of endorsed that the kid should think about suicide, or this is how you do it. That is absolutely awful. But there are also millions of people today getting mental health help through chatbots in ways that probably are advantageous, and it's convenient and very low cost. And again, try to find a mental health counselor in San Francisco. It's not that easy. So I think it is going to be really tricky, but important for us to try to figure out how to do apples to apples comparisons of the safety of these tools compared to the existing system, not some mythical state of perfection.
Yeah, I love that. I think you're dead on about comparing to the system that we have versus a perfect system that does not exist. But I am concerned about what the coming years look like, just given the likely realities. But we've also seen some bright spots, I'm surprised to say, from the current administration. Let's talk about it, because last night I was also at an event with Ruchika Fernandapillai, you probably know, who was the founder of Iora. Some people say that the father of value-based care. And we talked about one of the issues with fee-for-service as it relates to AI, that fee-for-service and all the billing that surrounds it was really created for a time when you had scarcity, right, baked in. And now we're talking about a future where care could be far more abundant. The autonomous systems that we're developing, like the one we talked about in Utah, have endless capacity to see patients. So how do you bill for these things? I think he became quite excited about the potential of value-based care in this context, which is really about paying for outcomes. Taking us back to this current administration, the access model that just got announced a few weeks ago, where we're looking at a potential payment mechanism for all these new technologies and tools that can actually get to better outcomes. And if you get to better outcomes, you can get paid, and that can include AI if it does drive those outcomes, again, for people with chronic conditions. So, Bob, tell us, what do you think? Is this going to usher us into a new payment model, or are we going to be stuck with fee for service for the next 20, 30 years and trying to make AI work within a system that it really was not meant to? It's like pushing a square peg in a round hole.
Value-based care taking over American healthcare has been just around the corner for 25 years and mostly remains around the corner. There are a lot of forces that get in the way. I could see AI accelerating the move to value-based care, in part because if you think about how do I charge for each tool, eventually it becomes like buying a car and saying, well, your windshield wipers are AI enabled, that's an extra charge, and your steering wheel is AI enabled. Eventually it just gets absolutely silly. I could tell you, at UCSF, we're still mostly in a fee-for-service environment. And I think our incentive to use AI, if it makes care better and safer and more convenient and more accessible and less expensive, is still pretty good. It's not like we say this is going to lead to fewer patients being hospitalized or free up the time for primary care doctors from doing paperwork. Therefore, we don't want it because we bill for widgets. That's not the way most healthcare systems think. We have more patients that need our care than we have time for. It costs lots of money to recruit and retain doctors and nurses. If we can make their lives better and allow them to focus on high-value tasks, I think we will tend to do that. We have a moral and ethical obligation to try to provide really good care. We're in a very competitive environment. So if AI-enabled care is better and more convenient for patients and we don't have it, we're probably going to lose patients, which is not good even in a fee-for-service environment. So I guess I'm not convinced that the only way that AI really reaches its full potential in healthcare is that we have to switch to full value-based care. That said, it makes more sense to have a system where a healthcare organization is paid to take care of a group of patients and has an incentive to keep them healthy and out of the hospital. And I think this probably accelerates that at the margin, but I don't see it completely being dependent on making that move. I think a system, if you're Kaiser and you really have an incentive to keep people out of the hospital, you're probably going to invest more in AI tools that keep people healthy than a system that doesn't have that incentive. But I don't see this as dichotomous. And if we don't go to value-based care, AI doesn't really flourish, because I think the forces, even in the existing system, are pretty powerful.
Okay, so I want us to focus a little bit to the book, because you are definitely somebody who got me excited about writing my own book, who I think complained to at various points in the process, because actually writing a book is so much more than you think. And, there's a lot of people out there, I learned, that do not actually write their own books. You can just pay people to write your book for you, which is pretty incredible. But you are not one of those people. I am not those people.
I am not.
Makes you want to tear your hair out sometimes, but you do it anyway. So, Bob, reflecting back on just the process of this book, what was some of the highlights, lowlights? Was this one easy to write? Did it just pour out? Was it a really hard one for you because it was this whole new realization? What was it like?
A joy. I have to say, first of all, I like to write because I like to think, and I like to try to, part of what I do for a living is try to think about big, complex, multidimensional issues and then figure out how to make sense of them for both people in my profession and people outside of my profession. I did a lot of that during COVID, and I enjoy doing it. I enjoy taking in the information, learning from people. I'm very curious, and then seeing if I can make sense of it myself and then translate it out. The things that were unique about when I was asked by the publisher to think about writing a book on healthcare AI, which was exactly 2 years ago, I said no. And I said no for two reasons. First of all, there's going to be a ton of books out there already. And the answer is there are some, but none that do what I think I've tried to do, and I think successfully. And the publisher kind of convinced me of that, because a lot of these books are written by tech experts, and I don't see myself as a tech expert. I see myself as an expert in the system and how it works and how doctors think and how systems kind of organize themselves. And it turns out I think that's probably the most important perspective, rather than really understanding what's going on under the hood of the technology. Second reason I was reluctant to do it is I said, the minute this is out, it's going to be out of date. And my publisher, to their credit, said, if that's true, then you've written the wrong book. I think that the book I tried to write was one that's not dependent, are we on GPT-5 or GPT-12, but asks the big fundamental questions, exactly the ones you're asking. How does this influence the payment system? Will there be doctors in the future? Who's going to win, startups or Epic or Google?
Oh, I want to ask you that
Yeah,
question.
but all of those things, those are the kinds of questions that I think are interesting and relatively timeless. What was different about this book was, as I was writing it, the fire hose of new information that would come into my inbox every day was unbelievable. What was also different was I interviewed 110 people. And first of all, they were excited to talk about it. This is front of mind for everybody. But the process was really fun, engaging, interesting. And at the end, I was really quite proud. I think I captured it in a way I wanted. I wasn't sure whether I'd land in an optimistic or pessimistic place. I came in pretty neutral about that. And I, in some ways, was surprised how positive I was about it. The one thing I really worry incredibly hard about is less job replacement and more deep fakes. The same technology that could create a digital version of Bob Wachter, who can see a patient and talk to them in the way I would, which is, I think, very exciting, could also have me, right now, me saying you should not take vaccines or you should, treat your
You
diabetes
should
with.
buy this hydrogen machine. It will
Yeah,
cure your
exactly.
Lyme disease.
All this craziness. It looks like I'm speaking and it's my voice. That I have no idea what we're going to do. And the final thing is that my publisher, which is a company called Portfolio, part of Penguin Random House, has been great and kind of believes in the book and has been really good on marketing. So it's just been a total pleasure.
Okay, so who is going to win? Is it going to be Epic? Is it going to be Microsoft? Is it going to be a VC-backed startup?
I'll give you a wimpy answer, which is in some ways all of the above. In the healthcare economy is big enough for there to be multiple winners. I think that there will be a bubble, although, as Casey Newton, the tech journalist, says, journalists have correctly called 25 of the last 3 bubbles. But I think if there's a bubble, it will not be so much AI in healthcare flaming out, but a lot of the startups are not going to make it. And Epic is really good and is doing a competent job putting out AI tools that are decent and are getting better and have automatic integration with the Epic system. I would have thought that they would have stumbled by now, because in some ways this was a whole area that was new to them 3 or 4 years ago. But when I talk to lots of tech insiders, they've done a pretty darn good job putting out tools that are always at least decent and get better over time. And they haven't really had a big stumble yet. They have made life very hard for some really wonderful tech startups. And I can tell you, looking at it from the perspective of a $15 billion academic health system, we are Epic first. We have made a policy decision that if Epic has it or is coming out with it in a year and we think it's going to be good, we're probably going to go there first before doing a startup, both because of the integration and also we know Epic's could be in business in 5 years. We don't know that a startup is. So I think Epic has an advantage. I think it's an interesting question whether it's an unfair advantage. They take advantage of their incumbency to make it more difficult than it should be for the startups. I think that's a policy question that has to be resolved. In terms of Microsoft, Google, et cetera, these companies always seem too big to fail in healthcare, and yet they always do fail because they're just so far away from the frontline work and how healthcare actually works. That's despite having some very good clinicians in their tent. They're more mature about it than they were over the last 20 years. They'll have a role. They'll do fine. I would not bet on them, except in areas that are just part of their core competency. Amazon delivering its medicines to you is just as easy in some ways as delivering a book to you. That they'll do great in. But in terms of really doing healthcare, I would bet on Epic over the startups. I think there will be some great companies in the startup world, but there are going to be a lot of companies that don't make it.
A lot of it comes down to capitalization. We had Neem Gandhi, who's the CFO of Mass General, on this podcast recently, and he made this point that, you look at a startup that has a $5 million C round. 5 million sounds like a lot of money, but a big health system can take 3 years sometimes from the first meeting all the way through to now this thing has been implemented and rolled out. And a big health system has to look, do you have enough money to take you through that process? And somebody like an Epic has billions upon billions of dollars. So I can understand why it's a safer bet. So Last question on this, and then I want you to share with the listeners about how they can get the book and when they can get the book. OpenAI, that's the other company that's had some news this week. They launched ChatGPT Health. I'm not sure if you've given it a whirl yet, but I will just go out on a limb and say I use ChatGPT all the time for medical questions. If I ever get a scan, I throw it into ChatGPT. If I get lab work, I throw it into ChatGPT. I'm using it for medical reasons. It's not just wellness reasons. I believe that the data has shown that millions of consumers and patients are doing the same thing. They use it for medical. So I was interested, and I think Rebecca Mitchell from Scrub Capital, my co-GP, made the point that she was a little bit surprised that a lot of the early partnerships were with more the wellness type companies, the wearables type companies, and less so that ChatGPT had some kind of integration to offer true medical visits. So what do you think? Do you think it's going to keep going down this kind of more health, wellness, but more wellness path, with questions like, how do I optimize my sleep? What kind of steps do I need to get every day? Or do you see a future where there are actual medical visits happening? There is prescribing happening. There is much more of this medical functionality. And I think that is a massive decision that the company has to make.
Yeah. I think patients and doctors are using AI to help them make diagnoses, throwing in symptoms. And what GPT Health basically does, it's a big deal, but not a big deal. It's a big deal in that if you go to GPT or Gemini and you say, I have a headache, and you say, what do you think is going on? It'll give you a generic answer. But if it knew that you also have diabetes or have lung cancer or a history of migraines, it will give you a more customized, personalized answer. And the only way it can do that, obviously, is knowing your past medical history, knowing your medical record. So the search that is in GPT Health is the same search you will get if you use just regular GPT. The real step forward here is that you now have the capacity to load in all of your medical records in what they're claiming is a completely safe, private environment. Patients are going to have to decide, do they believe that or not? Because OpenAI is not bound by HIPAA. So you've got to make a decision. Am I comfortable porting all of my medical information in there? It seems like it's more likely to give you a better answer if it knows your past history than if it doesn't. I think the combination of the Utah announcement and the GPT announcement are very interesting because it basically says these tools are moving into a mode where they're going to be more able to give you a personalized recommendation. And let's say it sounds like you have a urinary tract infection, you should be taking this antibiotic. But now I've got to call a doctor's office to get a prescription. Can you imagine a world where it then prescribes your antibiotic? Of course. Do I think that's bad? It could potentially cause harm, but I could also see a way where that's fine. That's perfectly safe and more convenient for patients. So it's yet another step forward in moving these tools into more of the world of mainstream healthcare. Where this goes over time, it seems obvious to me that if all of my medical information is in Epic or Oracle or Athena, and the idea that I've got to port it into GPT, maybe a less safe environment, seems kind of crazy. Why hasn't we built AI into my chart, into Epic? It knows all my information. I put in a query, it answers it. If I actually do need to see a doctor, it schedules me to see a doctor's appointment. It should all just be integrated into a single pathway for patients to get their care. And that's where that's going to go. And interestingly, on the physician side, the same thing is happening. All of our doctors now use open evidence as decision support, which is essentially GPT for doctors. It's really quite good, and there's a lot of confidence in it. It's not integrated into Epic at UCSF. So when I'm on rounds and I've got a question, I will pull out my phone. I'll be careful about HIPAA, but I'll say I'm taking care of a 62-year-old patient with chronic lymphocytic leukemia who comes in with a fever and a white count of 7 and a creatinine of 3. What do you think is going on? It gives me good answers, and it's useful. It essentially is what we call a curbside consult, but it's in my pocket. But again, that's silly that I've got to enter all that stuff in the phone as opposed to Epic knows all that information about the patient. I put it in there. Why can't I just say, Epic, what do you think the diagnosis is and what's the appropriate treatment for this? So blending in computerized AI-driven decision support into our existing workflows for doctors and for patients is where this goes. And I see these steps this week as just sort of baby steps in that direction.
Definitely a huge news moment and perfect timing for the book, which is soon to be released. So, Bob, tell us where we can get the book, when we can get the book. And I'm excited myself to be hopefully an early reader if you'll send me a copy.
I will get one to you as quickly as I can, and it will be out on February 3rd. It will be available where people get books these days, at pretty much every Amazon, Barnes and Noble, and I also just started a Substack to sort of update new issues as they arise, including just writing one now on both Utah and ChatGPT Health. I think there are things that are coming up that if that had happened a year ago, they would have been in the book, but they're happening now. But they follow on the themes of the book, that how does this change the lives of doctors, patients, nurses, health systems, leaders, tech executives, investors. If I couldn't make that book interesting, then I stink as a writer, because this is the most interesting topic I've ever seen in my 40 years of healthcare.
Well, I appreciate you so much, both as a physician and a communicator. And it seems like you take both roles extremely seriously. That's not something you often see in the profession of medicine. This idea of being a communicator is not my job, not my problem. And you've not felt that way, which is why you have such a big following, which is why you've written so many books throughout your career. Thank you so much for joining us on the podcast. And everybody listening, I hope you go buy the book and let us know what you think.
Great. Thanks so much for having me.
That's a wrap on Life Is. If you know someone else grinding it out in healthcare, send them this episode. And if you want more unfiltered takes on digital health, check out the Second Opinion newsletter, link in the show notes.